Okay, well, we want to welcome everyone to session number 4 of our Aging and Elder Care series. This one is on Medicare and Medicaid and all the different options. Matt Santelli from Pierce County Aging and Disability is here, and he's going to help us make sense of all these intricacies that make up our Medicare and Medicaid system that can be really confusing. My name is Jen Killian. I'm a lieutenant paramedic with East Pierce Fire and Rescue, and so glad to be collaborating with Pierce County Aging and Disability and Matt in bringing this series to everyone. We know that this is really valuable information. Matt has dealt with a lot of this personally and professionally. I also have dealt with it a lot personally and professionally in caring for my aging parents. So while Matt's going to be the star of the show, I'll pepper in a couple of my own thoughts here and there, and hopefully we bring you some really valuable information. So without further ado, Matt.
Great, thanks, Jen. Appreciate being here, everybody. And we're going to talk about Medicare first, and then we'll talk about Medicaid. My name is Matt Santelli. I'm Education and Outreach Specialist at the Pierce County Aging and Disability Resource Center. At the conclusion of both presentations, there's a resource page that you can access, and which can give you some additional guidance. Medicare right now is at least as confusing as Medicaid, so don't feel bad. Years ago, it's amazing because when I started this job, 20 some years ago, Medicare was much more simple mechanism than it is now. Basically, back in those days, you had A and B, you might add a supplement. But then when they did the Medicare reforms with the Affordable Care Act and other things that happened in the 2000s and later, it got much more complicated. So that's why we do these presentations, to have folks understand it a little bit better. And I always give the disclaimer that we're coming up on open enrollment, which is October 15th to December 7th. And benefit availability and other things will still be established as we come into October, Medicare open enrollment, October 15th. So we're going to take a view of what we think we know in terms of what happened this last year, but things will still change into fall open enrollment. We always encourage folks to talk to family, talk to professionals, Medicare guides like the state health insurance benefits advisors, talk to your doctor about things that might be medically necessary that you can benefit from under Medicare, and use the Medicare plan booklets. The Medicare and You 2026 booklets, I believe, should be coming out here in the next few weeks. We're referencing the Medicare 2025 booklet when we talk today. Next. Okay, so some changes to Medicare open enrollment. Social Security offices right now double as Medicare guidance offices. So you don't have just a freestanding Medicare office out there. You have to use Social Security's offices. And in my experience, they're minimally trained on Medicare stuff. So we really prefer that you use resources like our office, like the state health insurance benefits advisors. We have some trustworthy Medicare brokers that we're professional partners with as well. So talking to Social Security, not going to help you as much live in person as talking to some other entities. Plus, they're taking appointments now. You can't really walk in and get questions answered. So if you're already on Medicare, we always recommend that you can call Medicare directly at 1-800-633-4227. If you're not yet on Medicare and you're coming into Medicare eligibility at age 65 or having been disabled for 24 months on Social Security disability, Social Security is the first step to getting you approved for Medicare because they establish eligibility based on their record. So in those cases, yeah, you would talk to Social Security, 1-800-772-1213. And just a reminder, the cost of living adjustment this last year on Social Security was 2.4%. Hearing rumors it's going to be a little bit higher than that, 2.7, 2.8%, but we won't know that for a little bit of time yet. Next. So some basic information about Medicare. Medicare is your health insurance coverage linked to your lifetime earned income or the earned income of your spouse. And typically, if you're claiming on a spouse's record, you would have to have been married at least 10 years to do so for both Social Security and Medicare. Most people here in the US that have actively worked or married to someone who was actively working qualify at age 65. Even though Social Security full retirement age can vary anywhere from 62 to 67, Medicare eligibility age in terms of when you age into it is still age 65. Other people can qualify for Medicare, as I mentioned, after having received a cash payment from Social Security disability for 24 months or due to a specific diagnosis. There's a whole list of compassionate allowance diagnoses that Medicare allows pretty much immediate eligibility for, including things like ALS and end-stage renal disease if you're on dialysis. So not everybody qualifies just waiting until they're 65. Some people qualify younger, but it's based on their Social Security disability status. Initial eligibility, like I mentioned, is always verified and completed by Social Security. So for example, my wife turned 65 a couple of years ago. In that month she was turning 65, she had 2 months prior to that to call Social Security and say, hey, I want to go on Medicare, or she would have had the Medicare month or 2 months after that as well. And you need to sign up when you're eligible, because there are late enrollment penalties if you don't sign up. And so there's some exceptions to that rule where you can avoid the penalty. But in general, if you're out of the workforce or finishing work, you turn 65 in that month, you have 2 months prior to that month, you have that month, and 2 months after that month to call them and get set up with Medicare A and B. Medicare, again, the card, red, white, and blue card with your name, effective dates of coverage for parts A and B, and an ID number for medical billing, which is now a non-specific random combination of numbers and letters. We as advocates for years were saying Medicare cards are somewhat at risk for identity theft because it was traditionally your Social Security number with a letter at the end of it. Now it's a random combination of letters and numbers. So the Medicare and You handbook, which I'm referencing, is last year's handbook. You should be getting this year's handbook, which is relevant for next year, here in the next few weeks. Usually I think the rule is by the feds that they have to have it mailed out to all recipients by the end of September. So that should be coming in your mailbox soon. And in that book, what you're going to read about are the different parts of Medicare. Medicare Part A is the first part, covers anything related to inpatient hospital care and skilled nursing facility care. So when we talk about what do the different parts cover, that's what A typically covers. When you are admitted into a hospital and you're having treatment for an illness or an injury in the hospital, or if you're stepping down from that hospital to a skilled nursing facility, then you're still on Medicare Part A. That skilled nursing facility benefit pays at 100%, usually only for the first 20 days that you're there. So any more skilled nursing is really short-term rehabilitation. At one time, it was more extended care, and it can still be that if you go into skilled nursing and you're not well enough to leave within 20 days. But in most cases now, your treatment team in that skilled nursing facility is going to look at a 20-day period for rehabilitation for you. If it's recovery from an illness or you had a hip replacement, whatever the case might be. There could be deductible and co-pay costs for Part A services. In general, this last year, 2025, the hospital deductible was $1,676. What that means is anytime in 2025, if you were admitted to a hospital for a procedure, treatment, illness, or injury, the first 1,676 was going to be billed to you. The remainder is typically covered at 100%. That's on original Medicare. There's some variation on that with Medicare Advantage, but on original Medicare, that's where it sits. And then Medicare Part B, as in boy, covers outpatient physician visits, lab work, and diagnostic testing. So anything happening on admission in that hospital building or skilled nursing is Part A. Anything happening out in the community, doctor visits, laboratory tests, MRIs, CAT scans, all those things are covered on Part B. Also has some premium deductible and copay costs. In 2025, the monthly premium to be on Part B was $185. Part A typically has no monthly premium, and the yearly deductible on Part B was $257. Part B enrollment can be delayed, meaning with avoiding that late enrollment penalty, if you're still actively working or you're married to someone who's actively working. So an example of that, again, goes back to my wife. I'm actively working with the county. She was no longer working with her brother's legal office. And so when she turned 65, she called Social Security and says, I wanted to take Part A only and defer my Part B and Part C and Part D because I am actively working. That's the only circumstance where you can avoid signing up at age 65 and avoid the penalty if you're actively working or you're married to someone who's actively working. So when I finish working, she has 7 months from the time that I separate from work to add her Part B and D without incurring any penalty. So there's a grace period once you finish your active work, at which point you or your spouse can sign up for Part B without any penalty. Now, I'm not 65 yet. So if I turn 65 and I decide I'm still working, then I can avoid signing up for B as well. And this is basically holding you harmless because there's really no reason, typically in most cases, to incur that $185 a month premium while you still have coverage at work. But you still want to have the Part A because there's no premium attached, and that'll coordinate benefits with your active work coverage. The general rule, I believe is if it's an employer of 50 or larger, Medicare goes into the secondary position on billing. If it's a smaller employer, then Medicare goes into the primary position on billing. And that's in terms of coordinated benefits. Next. So what is Medicare open enrollment about? This is where we're getting into that aspect of Medicare coverage. During open enrollment, your Medicare Part C comes into play, known as Medicare Advantage. Those are plans offered by private and nonprofit, for-profit and nonprofit commercial insurers, places like United Healthcare, Aetna, Cigna, Community Health Plan, Kaiser, Regents, Premera Blue Cross. They all offer what are known as Medicare Advantage plans. So Medicare Advantage plans manage your Medicare benefit on your behalf. And in some cases, you pay them to do that. Some cases, they have zero premium plans. But in most cases, there are some premiums, deductible, and copay costs. They have networks of providers. So the starkest example of that is Kaiser. My wife and I are on Kaiser through county employment right now. So assuming we go into the retirement world on Medicare, we would probably look for a Kaiser Medicare Advantage plan so we can maintain that Kaiser network of providers. Other plans aren't nearly that rigorous on their networks, like Humana is an example. They have a very wide network that spans Multicare and Franciscan and other local provider networks. But you can have much more rigidly managed plans like Kaiser, for example. Community health plans, another that typically uses their community health care providers. End-stage renal disease is now eligible to enroll as guaranteed issue. So year to year during open enrollment, everything is guaranteed issue. Most, if not all, diagnoses, even if you had cardiac problems, even if you had cancer, even if you were diagnosed with dementia, even end-stage renal disease. Year to year, you can change your Advantage and D plans. It's guaranteed issue. In other words, they can't deny you based on your health situation. And then Medicare Part D, different than Medicare Advantage because it doesn't include that other management of the benefit. That strictly is standalone prescription drug coverage. So this is where people get confused because they have all of these choices. If you look in the back of your Medicare booklet that you're going to get, it's going to have tons of pages of choices you can make, combinations of Advantage plans or D plans. Most Advantage plans that are offered in Pierce County include the prescription benefit. So there's this odd anomaly where there's Advantage plans that don't charge you a premium that include the prescription coverage, but there are no-cost prescription plan alone coverages. So that's why most people are incentivized when they're looking at Advantage plans in open enrollment to just join an Advantage plan that includes the prescription coverage and often also includes a no premium plan and has additional benefits, things like health club memberships, vision, hearing, dental. Original Medicare has none of that. No wellness plans, no vision coverage, no dental coverage, and no hearing coverage. Now, original Medicare does cover for diseases of the eye, like cataracts or glaucoma, but not for routine vision upgrades like eyeglasses. Also, remember, Medicare does not pay for long-term care. Medicare Part A pays for limited time skilled nursing facility care and home health care for rehabilitation only. Time limited based on an illness or injury from which you're recovering. Once you've maxed out your recovery, then you're done with that part of the benefit. All right. So open enrollment this year will extend from October 15th to December 7th, 2025, like I mentioned, allows you as a Medicare beneficiary to make changes year to year. So if you were on the Humana plan this year, you were unhappy with the coverage, whatever reason, you could say, I'm going to switch to an Aetna, or vice versa. Or you could say, I'm happy with it, I'm going to stick with it, it's just going to roll over automatically. So in addition to your Medicare and You booklet, you're going to get a guidebook from your current plan that tells you if any of the benefits are changing into that new year. So you're going to want to look in there and check like things like premiums, deductibles, copays. A lot of them are moving to like a preferred versus a network pharmacy kind of setup, where you're going to get a better benefit on your copay cost if you go to a preferred pharmacy. So make sure when you get that booklet in the mail that you read through it and double check everything, okay? No need to make changes if you're happy. It'll automatically renew, but please read through there. The other thing I always recommend is that you verify with your doctor's offices and ask them, are you still a Humana provider going into 26? Are you still an Aetna provider? Whatever the case might be. Because in my experience, the plan-sponsored network directories aren't necessarily reflecting current reality when it comes to what your doctors want to do. Next. Okay, so there is a hold harmless period on Medicare Advantage plans, typically through March of next year. This is March of 25, but typically through March of 26. So if you join an Advantage plan and then you get into the new year and for whatever reason you're unhappy with it, you can drop that plan and go back to regular Medicare with a D coverage. That's because what typically happens is sometimes people make changes on their Advantage plans because they're chasing a benefit. They're chasing a health club benefit or a vision benefit or a dental benefit, but then they get into the new year, they didn't do all their due diligence, and their doctor might say, oh, by the way, I'm not taking that plan this year. That's why you have this period to say, oh, wait a minute, I made a mistake, and make a change back to original Medicare if you have to. Most plans include health and drug coverage, like I mentioned. They can offer additional benefits, things like dental, vision, hearing. Some of them offer health club memberships. Some of them offer door-to-door transportation to doctor's visits. Some of them offer over-the-counter purchasing cards and discount cards for over-the-counter medications and for equipment and things like that. Those are all things you should see in your benefit booklet each year. And there's even some that are incentivizing veterans to join. The veteran system is basically a parallel system. So Medicare, veteran system, TRICARE for Life, those are all kind of parallel systems. The veteran system kind of stands alone. The TRICARE system overlaps a bit with Medicare. So again, I would recommend that you talk to our Shiva folks, advisors, or a Medicare broker. You can always call our office, 253-798-4600, and we'll get you connected with the folks who could dive deep into these choices you might be making. In general, the trend has been that more and more people are joining Advantage plans. So we we've crossed over that tipping point of 50%. Right now, 31 million people on Medicare are in Advantage plan. That's 53% of everybody on Medicare has chosen to join an Advantage plan. That's where all the action is. So whether it's been Republican-controlled administrations, Democratic-controlled administration, they all typically kind of coalesce around this idea of adding to Advantage plan benefits. And that's why all of these benefits are bigger than they used to be. Now, they might be smaller some years, but in general, they're expanding beyond what original Medicare offers, and that's how they bring people in. However, the caution on that is, during this time of year, Medicare provides these companies with your contact information. So you're going to be inundated with mailings. Sometimes you get robocalls and all these things saying, join our plan, look at all these great benefits. That plan choice is very individual to your situation. So just because they're marketing to you doesn't mean they know anything about you. They just want your business. So keep that in mind. Next. So this is the last year's Medicare and You book. Looks like this. You're going to get one very similar to this here in the mail very soon. It is a resource. So next, let's take a little bit about what's in that handbook based on last year's book. Lots of great information comparing Medicare, Medicare Advantage, and Part D coverage. A comprehensive list of Medicare Part B covered services, including all the preventive services. Those services are going to be available to you based on your age and your medical history, okay? So you want to have those discussions with your doctor to say, okay, which milestone ages am I going to need certain tests, like colonoscopies and other screenings, bone density screenings, cardiovascular screenings, aortic aneurysm screenings, all these different things. And much of what they're going to do is also based on your medical history. So you need to let them know your history of illnesses and injuries. You need to let them know those first-degree relatives, brothers, sisters, mothers, fathers, uncles, what their illness history looked like, because that's going to dictate to you the frequency of the tests you're going to have done. So let me give an example of myself with colonoscopy. My brothers had cancer. My uncle died of colon cancer. My dad had colon cancer. My grandmother had colon cancer. So one thing they're doing for me now is they're testing me on the colonoscopies every 5 years because of those high risk categories of those first degree relatives. So that wouldn't be happening but for me telling them what my medical history is. So very important to have those discussions with your doctor. Other thing to remember too is that all of the CDC recommended vaccines, shingles, pneumonia, RSV, flu, COVID boosters, those are now all covered by Medicare at 100%. So that's the time to get them when you're healthy, of course, especially things like the shingles vaccine, the pneumonia vaccine. Those are known to be pretty reliable, what are known as sanitary vaccines, where if you get those vaccinations, you're unlikely to get the illness. And what we found as we get older, those inflammatory response illnesses like pneumonia, shingles, can be very damaging for the long term for both our body and brain health. So keep that in mind. Now, the other thing I'll caution you is that I got the shingles vaccine a couple of years ago. It's a 2-dose vaccine. And like a fool, I got it on a Friday and scheduled a day of events on a Saturday. I woke up on that Saturday feeling like I was walking through quicksand. I was so tired. So those vaccines are very powerful. So give yourself a day or two to recover. You might not have any side effects at all, but just in case, give yourself a day or two to recover if you get those vaccinations done. Good news in 2025, they added some additional acupuncture and chiropractic benefits on Medicare for specific diagnoses. Like I mentioned, all of the CDC vaccines recommended, fully covered. And this was the first year that they capped your out-of-pocket cost for prescription drugs at a total flat limit of $2,000. So even if you had thousands and thousands of dollars of expensive brand name medications, the most you would have paid this year out of pocket is $2,000. And this is a big deal because in years past, there was a gap in coverage, and then you had to spend, I think, up to $5,000 to hit the catastrophic level. And even then, you were still paying 5% of your prescription drug cost. $2,000 is the hard cap now. This is estimated to save consumers billions and billions of dollars. And we had a lot of people that are on very expensive brand name medications for diabetes and other things where they were basically running out of money during the course of the year. So this cap is a big advantage now. They've added access and support for behavioral health services and dementia caregivers, and they've capped insulin costs at $35 for a 30-day supply. Now remember, a lot of the things they're advertising about controlling your A1C as a diabetic, things like Wegovy and Ozempic, are not insulins. So right away this year, people have been calling, complaining, saying, wait a minute, you told me the cap is $35. Yes, if it's actually an insulin, even those are advertised as controlling some aspects of diabetic illnesses, they are not insulin. So keep that in mind. Next. Okay, there's also some Apple Health Medicare Connect plans. We're not going to go into detail on these, but basically these are plans for folks who are typically low income, low assets, who have Medicare because they've had an active work history, but in disability or old age, they're also on Medicaid. So it basically gives them an additional enhanced benefits because of that. But again, this is something you would find out if you were talking to a Medicare SHIVA counselor or broker. So we're not going to go into too much detail on those. They do have enhanced benefits, like I mentioned, additional dental service benefits, vision, hearing, additional transportation, and things like that. There's also some benefit on these for folks that are chronically ill with respiratory illnesses and things and are institutionalized. Next. Okay, so prescription drug Part D coverage, the basics. The premium costs can vary. You don't have to have Part B as in boy to have a prescription plan, only Part A. The deductibles can range from nothing to $505. During the deductible period, you're going to be paying all the costs. Then there's an initial coverage period where it's covering at least 75% of the cost of the prescriptions. And that continues through the year. And remember, then there's that hard cap. So even if that 25% you're paying starts to add up, it's going to stop adding up once you paid out of pocket $2,000. Then your coverage is at 100% for the remainder of the year. Like any prescription plans, they can limit what you're getting based on brand versus generic. And the Surgeon General of the United States, year after year, regardless of administration, has said a generic version has the same action as a brand name. Now, there's exceptions to that in dialogue with your doctor, but routinely they're going to say they're going to want to substitute the generic brand for the brand. Plus, there's quantity limits, there's step therapy, and doctor pre-authorization. So these are all designed to kind of limit folks from starting a medication that might not work for them. So basically, they're showing medical necessity by limiting quantity, by step therapy, and by doctor pre-authorization. So what do you want to think about if you're looking at D plans? Premium deductible and copay costs coming up in this next year. Are there discounts for pharmacies? What are the discounts for mail order pharmacy? Are all my medications covered? And verifying that they're charging no more than $35 a month for each insulin prescription. This really goes through year to year. These are the things when you get that benefit renewal booklet, you want to look, okay, next year, what am I going to pay for the monthly premium? What's my deductible? What's my copay? Is every medication I'm taking now still covered in their formulary? Now, they're required to send you a notice if they change during the course of the year, but otherwise, year to year, you have to dig into that booklet to find out if your prescriptions are still covered in the new year. The Advantage plan questions are very similar. Premium deductible copay costs, preferred pharmacies, formularies, insulin caps. The big thing that you have to think about on Advantage, though, are all my doctors that I'm seeing now or I might need to see again in this Advantage plan network? Because again, Advantage plans can have their own network of providers that they can limit your choices to when you need care, all right? And then you're also going to think about enhanced benefits like vision, dental, and hearing. But again, we always caution people, don't chase the benefits. There's a whole picture here that has to come into play, a whole puzzle that has to fit all the pieces to make sure year to year your care is as comprehensive as you need it to be. Next. Now, we're not going to talk a lot about supplemental plans because we're not relevant to have supplemental plan discussions to open enrollment. However, people do get Medicare supplements, and oftentimes people are on an Advantage plan and they think they're on a supplement plan and vice versa. You cannot be on both, okay? So a Medicare supplement from that original Medicare discussion we had basically covers the missing pieces of A and B coverage, like deductibles, copays, things like that. So you pay a fee monthly to have a supplement, so it picks up those extra pieces that are typically not covered in original Medicare, okay? It does not include prescription drug coverage. It does not have a provider network. It's simply a pass-through payer. And they're all the same based on letter categories. So if you have a Regence A plan versus a Primera A plan, they're still an A plan, but they can charge different premiums. And that's because it just depends on their saturation rate in Washington State, how many people they have signed up, okay? So sometimes you'll see these legacy supplement plans that are charging 2 or 3 times what a bigger economy of scale company is charging. So again, call us. We can send you a list of these supplements, and then you compare them in like a tracking sheet that shows from A plan to N plan what the costs are depending upon what carrier you choose. There's really not an open enrollment period for this. There's a guaranteed issue period on supplements in the first year after you start on Medicare Part B. Then they have to sign you up regardless of your health status. But beyond that, they can impose health screening. So you might have a history of cardiac care, cancer care, whatever, and they might say, no, we won't sign you up for that. The supplement plans used to be kind of the thing that we would really emphasize when we would do Medicare counseling for folks. Now the big players are all in the Advantage plan world. And some of the big players like United and others also play in the supplement world. But in general, supplements aren't the value they used to be because the expansion of value has been so broad in the Advantage plan world. Next. So if you want to make a change starting October 15th of this year, you can call Medicare and say, hey, I've been with this Humana plan, but now it looks like I want to be on the Aetna plan. They can make the switch for you. Your old plan will drop out. New plan will start January 1. You can go on Medicare.gov, look at your plan finder choices on there. It can get a little complicated, so I wouldn't advise that, but you could certainly do that. I would very much advise and recommend calling Sheba, State Health Insurance Benefits Advisors, at that number. They can actually sit down with you over the phone or in person at the library or at the senior center. Typically, they're spread out around the county and go over some choices for you. You can also go on the Healthcare Providers Council directory. We've got some excellent, trustworthy Medicare brokers at that website. Our local Sheba office is Sound Outreach. You can call them directly at that local number. And once you enroll in that plan for, this is a misprint, once you enroll in that plan for 26, my mistake, your current plan this year will terminate at the end of the year. So you don't have to do the trouble of calling your old plan and saying, I'm canceling you for a new plan. It automatically happens. Next. Okay, we also have what are known as Medicare savings programs for folks that are low income. To qualify for these plans, you just have to call us and we'll help you apply through DSHS to get on one of these plans that pays that Part B premium on your behalf. So that Part B premium, remember this year was $185 a month. So if your income was lower than say $1,800 a month, you might qualify for one of these Medicare savings plans. And then the state is paying that premium. You still have Medicare B. You're just not having to pay the premium every month. So you can imagine we have people that have $1,600 a month Social Security. They get that $185 a month premium paid by the state. That's an increase on their monthly income of close to like 14%. So yes, these plans are available. So another reason you would call us and have a discussion about your Medicare benefit. There's also what is known as extra help that limits your prescription drug costs and premiums and deductibles. That has even a higher income limit, but does have an asset limit. So we always think Medicare savings programs first because there's no asset limit. Reminder that the most they can charge you is $35 for an insulin prescription. And there's also some new Advantage premium reduction and give back plans that are typically linked to your veteran status. So we don't really discuss those plans a lot outside of discussing general Advantage plan choices. Next. So yeah, $1,752 a month on these savings programs. Married couple, $23.20 a month. There's a $20 income disregard. There's no asset limit. There used to be a very strict limit on this where you could only have like $10,000 in the bank. They got rid of that. So anyone can apply at any time during the year, or you can call us to help you apply. If you qualify, you're automatically going to get a reduction on your premium cost on your D plan or Advantage plan, and your prescription drug costs, co-pays are going to be capped at a very low level as well. Next.
Matt, what's the income disregard?
So basically that 1752 is actually 1772. I don't know why they do it this way. So even if you were $20 over that eligibility at 1752, they'll disregard $20.
Okay.
That's all. It's confusing, and they don't want us to list it differently. They always say you have to list a $20 income disregard.
Thank you.
Next. Okay, and these are the extra help eligibility. Income's a little bit higher, 1843 single, 2485 couple. but they do have these resource limits. And so that's why if someone comes to us and is looking to limit their prescription drug costs or save money on their Medicare coverage, we always think first, can we get them on a savings program? Because it doesn't have the asset limit, even though it does have the extra health income limits. These will probably change in the coming year. I think they change typically at the calendar year change. So this might line up a little bit differently in the new year, but again, just give us a call. We'll take you through it. It's unfortunate because apparently what I've heard rumors of is that the state of Washington, if they chose to, could match the savings program income eligibility to this federal program, but for no reason they haven't done that. So it'd make a lot of things easier for us if they did. So. Okay, remember, marketing. Anybody can call you, anybody can send you a text message, an email, a US mail advertisement. Just because they're sending it to you doesn't mean they know a darn thing about you. They're just trying to get your business, and in some cases it could be fraudulent. They're not supposed to text, they're not supposed to cold call, they're not supposed to robocall, they're not supposed to email you. The only type of marketing they're allowed to do is send you something in the US mail, okay? So ignore all that other stuff that says, oh, you forgot open enrollment, you owe a penalty, or your social security account's been frozen, and blah, whatever. That's all scams, okay? Avoid the scams. If you're not sure, don't respond to it, okay? That's the best advice. Thanks. And then remember, COVID boosters are going to be available here soon. I think for 65 and over, I think is the limitation now, although apparently doctors' offices can write an order for younger than 65. There's Pfizer, Moderna, there's one called Novavax available. And if you get sick with COVID, and I believe you're 65 and over or have risk factors, they can prescribe you treatment, 5 days worth, 3 medication pills in the morning, 3 in the evening. It's called Paxlovid. It's an antiviral medication. My wife just had COVID. She took this, turned her around quickly. 3 years ago, she had COVID. She took it, turned her around, so that by the end of that 5th day, she was testing negative. So remember, if you end up with COVID, they still have the home tests available. Call your doctor and say, give me a prescription of the Paxlovid. Okay, the side effects she experienced, it gives you a terrible, rotten kind of metallic taste in your mouth for 5 days. So you're probably not going to enjoy eating a whole lot, but COVID generally kills your appetite anyway. So, but please think of Paxlovid. Tell your friends that too, because not a lot of people know that's the actual treatment they have available if you're sick with COVID. Okay, the WACARES benefit, we're not going to go into depth about that, but WACARES is another term to describe the Washington Long-Term Care Trust Act. The WACARE benefit is going to be for active workers in the state of Washington who've been working actively at least 500 hours a year since July 1 of 2023. So if you've been working 500 hours a year, paid work, active work, and you're born before 1968 and you get to next July 26th, you're going to be fully vested in this benefit, which is $36,500. If you weren't born before 1968, then you will have to work another 2 more consecutive years to qualify. So again, call us about this. We can answer questions about this so people understand the benefit. We're the information and assistance outlet, the county aging disabilities offices where I work to get the word out on this benefit. Okay, next. However, there are scammers out there. So people are calling about WACARE saying, oh, you know, give us your bank account number and we'll pay you into WACARES even though you're not in the workforce anymore. That's a scam. Everybody that's actively working in the state of Washington, with some exceptions like tribal health employees and others, military employees, federal employees, otherwise, like me, that money is automatically coming out of my check. I had no say in the matter, okay? So it's coming out of my check, so don't fall for the scams there. Next. And our resources, you can always call us, 253-798-4600. Always call the Sheba office at the State Insurance Commissioner, 1-800-562-6900. You can call Medicare. If you're looking at information on Medicare appeals for denials of service, the KEPRO organization manages that. We've got Sheba on there and the Social Security number on there as well. So, any questions? Okay, so that's a very quick one through Medicare, and then we will jump to Medicaid, where things get even a little more complicated. So we'll talk about that a little bit.
All right.
And don't feel bad about confusion with Medicare. My son is now a PhD biochemistry researcher. He lives in Zurich, works for a worldwide pharmaceutical company. After he had finished his master's degree at Bellingham at West Washington University, he spent a year while he was working for the lab there as a Shiva volunteer for Medicare guidance. And he was calling me constantly, just overwhelmed, saying, this system is so complicated and so individualized. So if a brilliant guy like my son is confused by it, don't feel bad if you're confused by it as well. Okay, so we're jumping to the Medicaid world. So number one is that Medicare and Medicaid are two different things. Although oftentimes in articles you might read the two are conflated. Sometimes you'll hear politicians commenting on the systems and the Medicare's they're referencing is really Medicaid, what they're talking about. So please understand that they're different, but they're confused a lot, especially in the media. The two terms are used interchangeably, and they're not interchangeable. Okay, next. Okay, so we're going to try to make this very understandable. I do a whole professional level training on this where it really gets into the weeds. We're going to try to not get into the weeds too much. So when I'm talking about money in the bank, which is considered to be a resource. Sometimes when you read it, that's the language. Sometimes you read it as being an asset. So unlike Medicare, Medicaid does have an asset test and a resource test. So this question comes up a lot to people when they'll say, okay, I'm turning 65, I'm going on Medicare, I have money in the bank, is that going to disqualify me? No, that's not going to disqualify you. Now, if you told me I'm turning 65, I want to go on Medicaid and I have money in the bank, that very well might disqualify you because Medicaid always is linked to three things: your functional ability, your income, and your assets for older adults. Now, for younger adults, it's only linked to income and assets, actually only income. But as we get older, as we enter the Medicare world, it's linked to functional ability, income, and assets. Okay, and we're not going to go over every permutation of Medicaid. So for example, there's refugee Medicaid programs. There's temporary aid for needy families Medicaid programs. There's disabled children programs. We're going to talk about adults and then focusing more closely on older adults who are on Medicare to talk about Medicaid and the things they might need from it. So a few important things to remember. Medicaid is not transferable one state to another. Again, unlike Medicare. So if you are on Medicare here in Washington, you decide to move to Nebraska, you're still going to be on Medicare there, okay? You're going to have to choose different Advantage Plan coverages because those are not only state level, they're county level, but you're still going to have your Social Security, your Medicare. If you were to leave Washington on Medicaid, go to Nebraska, you have to terminate your Medicaid here in Washington and start brand new in Nebraska. And Nebraska's rules might be different, so you might not qualify there. Our review today is going to look at programs for single and married adults age 19 and over, not looking at children's programs, parenting programs, or refugee programs. And again, don't confuse the two terms. Medicare, for example, does not pay for long-term care. Medicaid, however, does pay for long-term care at home or in a care facility, but it has strict eligibility requirements. Medicare eligibility not linked to income or resources. Medicaid does link to income and resources, okay? Medicare does not pay for long-term care, Medicaid does. And so it's more complicated in that the eligibility is different. So again, if you're not sure, we're going to go over a few different types of programs that qualify under Medicaid. Just give us a call. Medicaid applicants are required to provide the Department of Social and Health Services who administers it. So again, Medicare is administered by the Center for Medicare Services, CMS. Medicaid's handled state by state. It's a federally and state-funded joint program that's administered at the state level by the Department of Social and Health Services. When you apply for a Medicaid program in the state of Washington, you have to give consent, you sign that application for them to search your financial records going back 5 years from the date of your application. This is known as a look-back period. That's used to determine if any disqualifying resource transfers may have occurred. Financial workers at DSHS can and will find both real estate sales and transfers and financial resource sales and transfer, which during that look back period may result in a period of ineligibility before Medicaid funding can be approved. So that look back period is designed to see if in anticipation of going on Medicaid, you started to transfer assets out of your possession to make it look like you were somewhat impoverished, okay? So we always tell people, if you're doing long-term care planning, talk to an elder law attorney if you have assets that you want to transfer out of your possession and maintain Medicaid eligibilities. There are legal ways to do that. Sometimes there's Medicaid qualifying trusts, annuities, different things you can do. But just wantonly transferring properties out of your name, for example, real estate, if it's in that 5-year look back period, they will find that information. Okay, they're gonna find it. So when people talk to us about applications, we ask them that question and say, oh, by the way, did you transfer any money, any stocks, bonds, real estate over the last 5 years? And a transfer could be as simple as providing a large sum of money to a family member. It could be quit claiming a property to a family member, whatever the case might be. So they're going to find those things. So that could disqualify you. Some Medicaid programs have look back periods, however, others do not. Regardless, there's no waiver of the look back period if you move from one program to another. So we'll jump into that a little bit as well. Also, the other thing that people are confused about is Medicaid has an estate recovery provision. So basically, the state of Washington Office of Financial Recovery, for anyone 55 or over, will do a one-to-one accounting on your Medicaid benefit to determine at some point later when your estate is settled, what monies you have to pay back to the state. And it just sits in this ledger book, adding up, adding up, adding up. So it's not unusual. We'll have a husband or wife who's been on the program. That person dies and the surviving spouse gets a notice from the State Office of Financial Recovery that says, oh, by the way, during their lifetime, your spouse accrued $20,000 in Medicaid services that is now needs to be paid back to the state. Now that surviving spouse is held harmless. They do not have to pay that money back. They just have to respond and say, I'm still alive, I'm still living in the house, or I'm still using that bank account we shared for my benefit, and then there's no lien or anything that's imposed. But if that spouse soon dies after, that spouse owing the money, whoever's managing the estate as executor is going to need to be in touch with the Office of Financial Recovery to pay that money back, okay? Let's see. Yeah, so again, the spouse is typically held harmless. They can continue to live in the home, whatever the case might be, until such time as that they die and the estate is settled. So, types of Medicaid we're going to talk about. We're going to talk about modified adjusted gross income Medicaid, Magi Medicaid, SSI Medicaid, Medicare and Medicaid clients, also known as dual eligible, and Medicaid programs that are linked to functional need for long-term care at home or in a care facility. Next. Okay, so this is the one that's probably the least relevant to anyone tuning in wanting to know more about older adult programs that are on the Medicaid umbrella. So the modified adjusted gross income Medicaid is linked to income only. We don't look at an applicant for disability or resources or functional need, and is a product of the Affordable Care Act. Many states still do not offer this program, which has come to be known as Medicaid expansion. So when you hear about Medicaid expansion, this is what they're talking about, okay? Traditionally, Medicaid, since I've been in this social services world, is linked to a recipient status as being aged, blind, and disabled. With this Magi Medicaid, it's linked only to income. So, and it's limited to folks 19 up to 65, not incarcerated, and not on Medicare. So once you're in the Medicare world, you can't participate in this Magi world. But if you were 64 years, 11 months, and 29 days, and weren't working, say you're just on a minimal amount of Social Security or not drawing Social Security, drawing down savings, whatever the case might be, you could potentially be on this Magi Medicaid program. So let's look at an example. Joe is age 27, has no income. He has $5,000 in the bank, which he saved when he was working. He quit his job several months ago because he needed to be a live-in caregiver for his chronically ill mother, not being paid to do that, not planning to return to work since he needs to stay home to care for her, not disabled, not on Social Security, disability, or SSI. He applies for Magi Medicaid and is approved simply because of having no income, even though he has some money in the bank, and even though he's functional. So this Medicaid expansion was designed to have some billable service available for this group of people so that if they're ill or injured, they can get care they need, medical care they need, and that providers can then bill that Medicaid coverage. Now, in general, Medicaid pays about 50% of what private pay insurance, like I have commercial insurance, pays. Medicare typically pays maybe 75% of what in commercial insurance pays. So when they talk about cost shifting and medical care, this is what they're talking about, because Medicaid shifts cost to Medicare, which shifts cost to the commercial insured people. Next. Okay, there's no premiums, no deductibles, no copays for people on this Magi Medicaid coverage. It includes medical and pharmacy benefits. The state recovery only applies if the person's 55 and older. There's no look back period because resources are not considered for eligibility. As of last year, I haven't updated this, it's a little bit higher. Income eligibility is $1732 a month, single person, $2351 a month, married couple. So even if somebody that's working part-time could potentially be eligible for this Magi Medicaid coverage. So, and then folks above this income level potentially could qualify in the healthcare marketplace in the state of Washington, where they could get maybe a high deductible plan at zero premium or a very low premium. So in the work that I've done over the years in the county, this has been a great benefit for the clients that we see, because in years past, there was a very cumbersome program where you'd have to demonstrate disability over a period of time to the state, and then they put them on what's known as a general assistance program, GAU or GAX. Now we can very quickly get them on this Magi Medicaid program, which is great. For example, I had a gentleman who was a high-tech guy, but loved to go biking. So he was out biking one day, crashed, head injury, wasn't ever going to recover his ability to do the high-tech work he was doing. He had like $40,000 in the bank, was living in a mobile home out here in Monty Lake or Buckley somewhere, as I recall. And so we were able to get him on that Magi Medicaid coverage. Now, he had some short-term disability coverage through his employer, but he wasn't able to work anymore. And he's not able to work, he can't go on unemployment because he couldn't participate in the workforce. So in years past, we would have been nothing we could have done for this guy, because we would have had to have adequate medical evidence to get him on GAU, and even then he wouldn't have qualified because he had money in the bank. But now we were able to get him on the Magi Medicaid, and so he could get treatment for the head injury, do rehabilitation, and all that stuff. So it kept him in his home, basically, because otherwise he would have been overwhelmed with medical bills and not getting any care. Next. Okay. This coverage of Magi Medicaid ends when Medicare begins at age 65 or younger if receiving SSDI. Once you move into the Medicare world, this Magi world goes away, okay? You cannot decline your Medicare coverage to try to stay on this. People do that. They get an overlap month where they can get an extra month on Magi. And so if they're turning 65, say in October, to go on Medicare, they still get that Magi coverage to the end of the month, but then it ends. You have to go on Medicare because the state is always looking to shift costs to the federal government. So remember, Medicaid is a combination funded program. Medicare is federally funded only. So the state is always looking to shift people onto Medicare. Magi clients not eligible for Medicare, such as SSI clients, still need to apply for traditional Medicaid at age 65. So everything changes once you get into the Medicare world. All the income limits, no resource limit, everything we talked about here changes once you jump into the Medicare world. Next. Okay, so we also have clients on Medicaid based on their SSI status. SSI is for someone deemed aged, blind, and disabled as defined by the Social Security Administration. These are people typically at an early age who were found to be ill or injured and never worked enough to pay into the Social Security system to qualify for Social Security disability. So this is someone that might have been mentally ill, had a psychotic break in their 20s, or have been mountain climbing and fell and injured themselves and never were in the workforce, and now they're paralytic or whatever the case might be. So they're eligible typically for SSI. The maximum SSI payment, $943 a month, single person, $1,415 a month for a married person. Very strict income resource limit, $2,000 single, $3,000 married. Those clients will be financially eligible for any of the remaining programs that we'll review during this presentation. So once you're on SSI, you're always going to be on Medicaid unless something significant changes with rehabilitation or something significant changes with that resource limit, okay? There are exempt resources, things like a home is exempt, burial plans are exempt, personal belongings are exempt, a car is exempt. So the SSI program is there to basically give some minimal amount of cash income to someone who never paid into active work deductions like Social Security and Medicare. It's designed to keep them going, basically. Now, we also have people that are 65 on SSI. We might have had a person that worked on minimum wage jobs off and on their whole life, and they're only getting, say, $600 a month on Social Security. We can add SSI to their benefit program to bring them up to $943. So they get $600 Social Security, $343 SSI, as long as their asset limit is still below $2,000 single or $3,000 married. Next. Okay, we also have folks that are Medicare and Medicaid clients. In these cases, a Medicare recipient can have Medicaid as a secondary coverage. There's different income limits for Medicare and Medicaid once a person enters the Medicare world, okay? So these are people on traditional Medicaid as an aged person, okay? There is a 5-year look-back period for eligibility for these folks because there is an asset limit and there's a state recovery as well. So in a rare circumstance where we have a very low-income person on Medicare who has very little money in the bank, we can have them get Medicaid benefits as well. So they're known as a dual eligible person. It's rare because the income eligibility is very low. It's basically that SSI limit of $943, and the asset limit is just $2,000. Next. Let's see. And again, they can still have those exempt resources like a home, cars, personal belongings, things like that. But again, if their income for whatever reason, or their assets for whatever reason jump above that limit, they're not going to be eligible anymore. If their income jumps above that limit, they're not going to be eligible anymore. Next. So if their income jumps above that limit, or is already above that limit, then they're on what's known as the medically needy spend down program, which is a challenging program for even us as professionals to really understand and figure out. So always call us about it. Basically what it means is, if you're trying to go on Medicaid and you're already on Medicare and you're looking at that $943 income limit and say your income's $1,000 a month, you're going to be on a spend down of $57 a month over a 3 or 6 month period, meaning that you're going to have to show you're paying out of pocket for medical costs to that limit. And then if you do, you're eligible for Medicaid for the remainder of that benefit period. Very hard to get on the program for a variety of reasons. Very hard to stay on the program as well. So again, call us. We don't do nearly as many spend down applications as we used to do, but we can still do them. Okay, how about long-term care? This comes up most often when we're talking about Medicaid. How do I pay for long-term care that I need? So for these descriptions on Medicaid for long-term care at home or in care facilities, we're assuming only one spouse is seeking the Medicaid funded care. Only the income of the spouse seeking care is reviewed for Medicaid eligibility. So COPES programs for long-term care in the home. This program, and COPES stands for Community Options Program Entry System, doesn't mean a lot. This is the program where we can get the most hours of care for a person needing it in their home. It provides in-home care for older adult or disabled adult clients age 18 and over who require help to meet their daily personal care needs. The care hours vary depending upon the client need, and it can be provided by a licensed agency caregiver or by any adult except for the client's spouse who completes the fundamentals of caregiving class and passes a criminal background check. So if someone comes to us and says, I'm declining or my mom's declining, she needs care at home, Is there any programs to help pay for that care at home? Because they're telling us it's $50 an hour. We don't have the money to pay for that. Neither does she. So the first thing we would think about is trying to get her on this COPES program. Next. Single person's income on this program could go up to $2,829. So in that example, if it's client contacting us herself, we would say, okay, where's your income? If she says it's under $2,829, boom, she'd be eligible. Then we would say, what money do you have in the bank? If she said under $2,000, great. She can own her home, belongs in the home, under $2,000, great. If she were married, we would tell her the resource limit is $68,301 combined. We would tell her then, what are your functional needs? Well, I'm having trouble getting out of bed in the morning. I need help safely showering. Sometimes I need help with medication management because I forget or I can't set up my medications. Then we would think, okay, it sounds like she might be eligible for this program because there has to be a functional need as well. There are a state recovery for these services, again, 55 and over, and there's a look back period as well. So we would tell her, okay, by the way, have you transferred any assets last 5 years? She says, no, great. And we remind her, okay, your house that you're living in now is not going to be attached while you're alive and living there, but when your estate is settled, that money you're going to bill out to Medicaid for your care is going to be attached to your estate, first position, that's going to need to be paid back to the state, okay? This trips up a lot of people. A lot of seniors will tell us, no, I don't want to leave an unencumbered house to my son, daughter. Other times they say, I've talked to son and daughter, they just want me to get the care. So kind of just depends on that family discussion. Next. So jumping from the COPES program, we also have this next program we look at called Tailored Support for Older Adults, also known as TSOA. So this program was developed with Washington State, among other states, being a pilot to see what if we added income eligibility, what if we added asset eligibility, but offered a limited amount of hours to folks who need it. Because back in the day, before we had these programs, it was COPES or nothing. You either qualified or you didn't. There was nothing else we could offer people. Now we can offer people this program. Higher income limit, $3,868 per month. There is an age limit. Person has to be 55 and over. They still have to have the functional need. There's never a situation of financial participation. It's either $3,868 above or below to qualify. Much higher asset limit. This one jumps up to $77,052 single, $145,353. Limited to 20 hours a month of care a person can get at home, and they don't get Medicaid medical coverage. They get the Medicaid caregiver help, but not the medical coverage. Anybody can do the care, including an eligible adult or an agency. Plus, there's no estate recovery and no look back period. So when we talked about billable hours and the state recovering that, that's not on this program. And there's no look back period. So if someone had transferred an asset 5 years prior to this application, it doesn't disqualify for them for this program. So the state was really trying to look at ways to get around a lot of the obstacles for getting people the care they need. Now, admittedly, 20 hours of care isn't a whole lot. And it's really, in most cases, when these clients approach us, really not enough to take care of their care needs, but it provides something instead of nothing. Next.
Sometimes it also provides that step. If I've found in working with some of our citizens that if they're resistant to the idea of having a caregiver in the home,
yes,
it kind of is a baby step towards that. And they then get used to the benefit of having a caregiver there and maybe then realize, okay, I need a lot more care. Let's go to the next step, call ADRC and figure out what next I might be eligible for.
Exactly.
So it's sort of a good trial period.
Absolutely it is. It's nice because it's limited hours, but the person still gets a professional case manager from our office. And we can easily, like Jen's describing, easily move that person from that TSOA status to the COPE status because the functional eligibility is pretty much the same. Some enhancements typically we would look at to make sure the person qualifies for COPEs. So yeah, it does get the foot in the door of getting them a little bit of care without some of these limitations on obstacles in terms of look back periods and things like that. And the asset limit is higher, but we can move them if they qualify for assets and stuff and income to the COPES program pretty easily. So. Okay, what about care in a facility? So say the person is no longer able to safely be at home, even with care hours in there, whatever the circumstance might be. How is that funded? So we can fund care through the COPES program in an assisted living facility or adult family home under these circumstances. Again, the asset limit the person has to be $2,000 or less. Married person, $71,394. Single person, the cost of care depends on the monthly payment rate as established by the Department of Social Services, Health, Home and Community Services, social worker, using what's known as a care assessment. So if that woman we were talking about getting care at home decided I need to go into a care facility, then the assessment would be done to kind of determine what the daily rate payable to the facility would be or the cost of her care. And again, it's probably going to be about 50% of what a private pay person would pay in that care facility, which is why most care facilities would prefer to have all private pay than Medicaid pay. However, we're very fortunate that we have a lot of family homes that do accept Medicaid paid clients. We have a handful of good quality assisted living facilities that accept Medicaid paid clients as well. So we're fortunate in that regard. Monthly payment rate is the amount of Medicaid payment that a facility would receive over the course of a month for caring for that person, usually lower than the facility private pay rate. And so in an example, and we'll do the example, the client's going to pay their whole monthly income, so assuming it's Social Security, they get to keep $100 for their own needs. The rest goes to the care facility. And then the Medicaid program is paying the rest of the cost of their care. So this question comes up a lot. Families will call us and say, oh my gosh, it's $6,000 a month for mom to be in assisted living. So we try to look at, is there a Medicaid option? Some facilities that would take that, they do, great. And so that whole question of, well, mom only has $1,000 a month. The social worker said the cost of her care is going to be $4,000 a month. Who pays the extra? The Medicaid program pays that extra amount. Okay, next.
Matt, let me ask you a question to see if you can address this. I've heard of a couple of instances where somebody is maybe in that spend down, right? So they're still on Medicare when they go into the facility. They have the assets to be able to pay for their care up to a certain point, knowing that at some point those are going to run out and they're going to need to go on to Medicaid.
Exactly.
But by then, like maybe they have an agreement with the facility, oh, we've got X number of Medicaid beds, so to speak. But then by the time they need Medicaid, they no longer have those beds or their system has changed and the person now needs to move. What's your experience with that? Or do you have any insight?
It's a great question.
It's a really challenging situation for people to end up in.
It comes out a lot because the quote unquote guarantee to me isn't quite a guarantee for a variety of reasons. Number one, they may be contracted to only have 2 Medicaid beds under the best of circumstances. And then, those might already be full. Number two, the actual administrator, whoever assigned that agreement, could be long gone by the time that time rolls around. Number three, we're seeing a lot of situations where actual facilities locally that once were locally owned and had some local community kind of commitment to them are being bought out by these national groups that aren't even in the medical business. They're just investment banks and things like that. So we always say, if you're going to take that look, talk to an elder law attorney to determine what type of contract would actually be enforceable in those situations. The other thing we typically tell people is go ahead and do that in asset spend down in a facility that right now we know admits Medicaid clients through the front door. Honestly, the private pay only facilities may have the fancy buildings and the beautiful landscaping. It doesn't necessarily mean the care is superior to the Medicaid front door facilities. So there's a lot of things we would kind of advise that family to do in lieu of committing to a year's worth of private pay with the hope that the person can still stay there. Because we've heard situations where they didn't end up being able to stay there.
Yeah, I have too. So call you all first is the best advice.
Some planning on that, yes.
Okay, thanks, Matt.
Great question, though. It comes up a lot. So one exception to the financial participation rule occurs if the client is married. Then the client pays $740 of their income to the facility. Income above that amount is shifted back to the spouse still living at home. So this is another method by which they hold harmless the non-ill spouse to make sure they have enough money to survive at home. And there's a whole formula that goes with it that we can help you out in kind of determining that. In no circumstance, and this comes up a lot, in no circumstance does the facility take over management of that person's income. Okay, people, maybe it happens in other states because it comes up a lot where people will say, well, I had to sign my Social Security check over to the facility. And back in the day, there was some truth to that because I worked at a group home back in the day in Auburn where the building actually had a financial office and we would dispense funds to the clients from their check every month. That can't happen anymore because there's just too many conflicts there, ethical conflicts to have that happen. So this, in the example we'll give, the woman still has control of her Social Security check, but she signs basically a rental agreement that says, while I'm here, I'm going to be paying this amount to the facility, the state's paying the remainder, and I get to keep 100. I think they added $3. I think it's $103, which isn't a lot for spending money, but all their medications are paid 100%, all their medical needs, everything else is paid 100%.
Meals, everything else, yeah.
So, skilled nursing facility, now let's go back one.
Okay.
So the example again, so say woman's name Jean, she applies for assisted living facility care. We help her do that. Her income's $1,000 a month. The Medicaid payment rate to the facility is $2,400 a month. She moves in. Out of that $1,000 every month, she pays that facility $900. That's her participation in the cost of her care. Keeps $100. DSHS Medicaid contract pays the facility every month the remaining cost of her care, $1,471.72, whatever the case might be. It's not even the correct number. But they pay the rest. So no one's on the hook there. Family members aren't on the hook. The person's not running a deficit, but they do need to pay. Now, there's been circumstances where people, for whatever reason, they don't agree with the care they're getting, they didn't like the food, they quit paying that $900. The state does not make up that difference. So that person at some point is going to get a notice of eviction saying you're not paying your rent to live here. So many facilities, because of those problems, will ask that there be an assigned power of attorney that's the responsible party to pay that money every month because they run into too many problems where people that were residents there, for whatever reason, decided to stop paying their portion of the cost of their care. So next. Okay, skilled nursing facility funding. It can also be Medicaid funded for long-term care. Typically happens when a person goes in, they do not recover on a trip from the hospital to the skilled nursing facility. They might get worse, they might have a stroke or infection. They're not well enough to return home, so they have to stay there long-term. Medicaid can pay for them to continue to stay there if the skilled nursing facility can keep them there on Medicaid. We have a few facilities around town that do not keep people on Medicaid, so they would have to transfer a very ill person to another facility. So again, this is another reason you want to talk to us to find out which facilities take Medicaid. Now, that's not always possible because sometimes the hospital are just trying to look for an available bed. So there might not be a facility bed that takes Medicaid there, but we could still help out with some guidance there. Again, the income eligibility is basically if cost of care is above your income, but it still has the asset limits for single and married people. In most cases, the Medicaid benefit would start once the Medicare benefit is exhausted, which is usually the 21st day of admission. So when my mom went into a care facility years ago, when she was admitted, she was recovering from a couple of head injuries she had from falling, but she had dementia, some other underlying conditions. Right away, they said to me, okay, what's going to happen at the 21st day? Are you going to apply for Medicaid or are you want to keep her here? And so we kept her there and we had the assets to do private pay when she was there. So, next. Client must have the functional need for skilled nursing level of care. And again, a skilled nursing facility is a medical facility. Unlike adult assisted living and adult family home, it is a medical facility. So a person has to be pretty severely ill to reside in a skilled nursing facility. In most cases, the step would be to get them from skilled nursing to a heavy care adult family home. That would typically be what we would want to do. In my mom's situation, we kept her there for a variety of reasons with her dementia. They seemed to know how to manage her better, and it was close to home. In another circumstance, we might have moved her to an adult family home. It's tough with the dementia overlay, though, because adult family home with an ambulatory demented person is kind of hard to manage. 5-year look back period in a state recovery position, just like for the others. One unique provision going into skilled nursing facility is that during the first 6 months a client is there on Medicaid, a client can keep a portion of their monthly income to pay the cost of their home upkeep. If they're renting, paying a mortgage, utilities, whatever, on the assumption that they're saying that within 6 months, I'm going to be well enough to return home. So the client has to declare their intention. The doctor at the skilled nursing facility has to sign and say, I talked with the client and they are declaring they will want to return home if they're well enough at the end of 6 months. That notice goes over to DSHS, so they're not paying that participation amount to live there. They're paying a very little amount, if nothing, possibly nothing, to support so they don't lose where they're living in the situation where they might be able to return. So again, this is something you can call us about. Otherwise, same rules apply. Client pays their monthly financial participation, usually their full income less $100, personal needs allowance. If they're married, their full monthly income less $100, and other household living expenses to support the spouse. So you can see that there's a whole world of Medicaid there depending upon circumstances. You could have a very healthy 20-year-old person on Medicaid. You could have a very sick 70-year-old person in a skilled nursing facility on Medicaid. You could have somebody at home doing just fine on Medicaid. You could have a sick younger person who's disabled on Medicaid and getting care hours at home. Just a bunch of different programs, different income levels, different asset levels, different rules on look-back periods, financial recovery, all that. So always recommend, if you want to research it, go on WashingtonLawHelp.org. All of the programs we described on Medicaid are listed there in plain language. You can read through a document that tells you all the eligibility, functional needs, income, assets, circumstances, all of that. Again, you could always call Medicare or on Medicare.gov about Medicare benefits. They can't tell you anything about Medicaid benefits. The same with Social Security. You can apply for Medicaid yourself through Washington Health Plan Finder if you're 19 to 65 years old and not on Medicare. Spend down SSI, COPES, TSOA, Skilled Nursing Facility Medicaid, that would happen through Washington Connection. You can also call us. We're happy to help out, navigate all these. We also have another program that's a non-Medicaid program called the Family Caregiver Support Program. Typically, we have husband and wife caregivers on there that are unpaid, so we can get them about 24 hours of help in the home. That's an income-based program, not an asset-based program. No estate recovery, no financial look-back period. So that's another possibility. So we always encourage you, just call us with the need, and then we'll start stepping you through possibilities of programs depending upon what the need is. And if it's definitely a long-term care need, we'll step you through and say, okay, there's a possibility. It could be COPES, it could be TSOA, it could be Family Caregiver Support Program if the assets are substantial and you're just looking for some relief help. So there's a lot of different things we could discuss with you if you called us at some level of need. And that is it on Medicaid, very quickly. Any questions on Medicaid?
Any questions online? Feel free to unmute or raise your hand. Okay, any questions? All right, I'm going to stop recording.